Yes, Dr. Sunil, we can see your screen.
Make it slideshow mode.
Can you see the slideshow?
Yes, sir.
Yeah. Thank you. Thank you very much. Thank you for inviting me or having me here. Thank you, Dr. Mehul and Dr. Grover, Namrata Sharma, madam, for organizing this. Thank you for the whole team. These are the hospitals which I'm working at, and I'm just going to touch upon the recent advances as what we are doing in multitude of these hospitals. My majority of the work is at DOVS Fortis at Vashi and Apollo Hospital and Raheja. Disclosures are none. The objectives I have listed here. I'm going to touch through all of these in a very brief manner. We know that there are various ways in which the optic nerve may be involved, but most of us, most of the time, talk about only the traumatic optic neuropathy, which is direct or indirect. But you can have a visual loss even with orbital apex syndrome. We have seen visual loss of keratoconus fistula and other syndromes as well. So what is this about? So what we do in our cases is that we have usually a 3D printout and we work on the 3D model and try to make out. So this is one patient in which we realize that there is a keratoconus fistula, and this patient has been treated as glaucoma for last 8 to 10 years. And the ocular pulse amplitude was very high on Pascal's tonometry, and that is how we realized. And then we figured out that you treat it and the patient is better. This was causing an optic neuropathy, which looked like a glaucomatous because it was slow, high pressure damage. So this brings me to bringing 3D modeling and 3D printing in the pre-operative planning of this thing. So when we look at investigations, I'll jump straight to investigations and management. When you look at investigation, the most important thing is a 3D model. You have a 3D model like that and you know where the fracture is. You take your 3D pen, you can, like a design, you can make the design on thing and try to figure out what you're planning to do and how you're going to approach. So the soft tissue in relation to the bone is something that you want to look at. So you don't want to look at only the 3D printout of the bone. You want to look at the 3D printout of even the soft tissue. Then you put the tissue markers and figure out where the optic nerve is. In surgery, the role of imaging is that you need an image-guided optic canal decompression when it is to be needed. You need a special order CT scan that is formatted to the stereotactic localizing system or the 3D C-arm. We also use color-coded maps. We use prognostic images. There are certain investigations that you need to do. You need to do a flash visual evoked potential and study it in traumatic optic neuropathy. And a ratio of greater than 50% is associated with a favorable visual outcome. The VP factor, the VP sensitivity is at 81% if it is looked at isolated, but if combined with other factors, even USG or OCT, it can be up to 90%. In USG, the color Doppler, ultrasound Doppler, the reduction of peak systolic velocity, end diastolic velocity, and the mean time is associated with a poor prognosis. You look at the fundus picture, very important because you would know, this is just as a quiz for students when I take lectures there. So you may realize how to look at the fundus and how to document and how to figure out that there is a traumatic optic neuropathy. This is outright clear. It is a transaction. But when you are dealing with such cases, you want to look at the role of OCT in damage assessment. And this is thanks to Dr. Sunil Moreker. And this is how you look at the OCT of the same transaction patient, and you realize that a raised area here and there is a vitreous traction there. He has gone ahead and done a vitrectomy and got a good result. So we also look at OCT of the optic nerve and try to figure out if there is edema as a swelling there. And you look at the height of the edema and try to figure out whether you need to intervene. You look at inside color abnormality, you can see that there is a slight color abnormality here, and we have treated this patient, and then you know that the color abnormality has been treated. We also use the electronic stethoscope. I have it with me. I'll bring it later on. With the electronic stethoscope, you get an oculophonogram in which you can see that this is an oculophonogram of a patient, and you realize that, look at that, and see the pre-op oculophonogram. There is hardly any pulsations heard. You're looking at pulsations from the optic nerve. There are hardly any pulsations here. This is pre-op of our patient, and this is post-op of our patient. So we also use an electronic stethoscope and a phonooculogram. Even all these, we used to look at poor prognosis as absence of light perception, fractures, steroids. all this is passé because none of this now matters to me. What matters to me that less than 6 hours, there's 85% chance of vision. And up to 24 weeks, there is a possibility of result if the USG parameters are favorable. And this in this contrast with Kanamori study, which restricted it to 20 years. So up to 24 weeks, we have had a patient with no PL in whom we have got vision back. So how are we doing this, and what is now for us what matters? So we know that the brain bonsai study looked at the brain and optic nerve study with artificial intelligence. We also know that papilledema, it has been studied, and AI has a sensitivity of 95%. We also know that disc abnormalities, which are associated disc abnormalities, there are 6 types of discs which are there. Papilledema or optic nerve injury in each of these types of discs is going to be different. And so you look at the disc edema, traumatic disc edema in such cases. And this is our paper where we use the Wolfram language, and we got the best paper this time. So the algorithms in AI can be further enhanced by using Wolfram language. The rationale for treatment is obviously to reduce the edema or take out the bony chip if there's one there. And most of us would end up using a steroid. And there is enough evidence for the role of steroid. And that is a list of evidences. And in case anybody is interested in taking this from me, this is a list of evidences for steroid use and good results of steroids. What is the current evidence? The International Optic Trauma Study is inconclusive. So if you're using the steroid, I'm using it on the Boston protocol, and within 8 hours of injury and endoscopic surgical decompresion within 12 to 24 since the beginning of the medical therapy. If improvement is reached in 65% of the cases, no major or minor complications, which as far as we are concerned. But looking at the crash study, if somebody wants to rush into surgery, or you think your gut feeling that you want to rush into surgery, I have taken a part of the crash study and realized that in select cases of traumatic optic neuropathy, surgeons may opt to bypass the use of steroid and proceed to optic canalicular decompression right away. The indications are very clear. Many of us know it. If visual acuity does not improve despite 24 to 48 hours of therapy, and if it deteriorates. Now, as far as surgical correction, the review is concerned, there are lots of papers and lots of reviews and other things on the surgical correction. So you got to be armed with this, because that is what you're going to need in case the patient goes in for a medical legal case. And you know, this is where my patient fit into. This is the study in which my patient fit into an endoscopic this thing, and this is where I did, and these people got it, we got the same kind of result. Iatrogenic injury is to be prevented. So many of these patients come with complex fractures. So this is my daughter who is doing CAD for kids and introduction to 3D design and 3D printing. So if so this is like kids can CAD. So if kids can CAD, why can't I? So we started using software. And we realized that between Vitrea and dextroscope, I personally do not find any difference. You look at 3D protocols, and like Lakshmi Madam said, you have to be very careful with titanium meshes because they can cause iatrogenic issues with the optic nerve. And you have to plan those implants. Like I said, we have the 3D skull, we have our pens, we have the art pens. These are simple pens which are available at 2,000 or 3,000 rupees. You create a model and you create your design, and this is what I'm going to do, and then you can ask them to print it. And those 3D printers and these 3D printers for the models are available for you to do it at home as well. And then you give it to the company to make it. And this is our customized 3D model. I slightly beg to differ that titanium does not work well. For us, it does. So probably the way in which you use is what really matters. Sometimes you have to screw based on volumetric modeling. So you have to keep the screw with the fracture fragments far away. You don't want to bring them closer and this thing, so that you don't want compression of the optic nerve. So you use this CAD. So I'm not going to say this is our worst case scenario. This is our patient in which we have operated multiple fractures. There is a plate there. There is a plate here. You can see the plate this way, that way. And this is a electric saw injury in which we have done the same thing. So 3D printed implants is something that can prevent injury later on. And you do a reverse origami approach. Why endoscopic? Because I do a lot of endoscopy. Is it because I am more comfortable? So you do whatever is comfortable for you. And intranasal endoscopy is favored because of the proximity of the optic nerve to the sphenoid sinus and the Onodi cell. Advantages of this approach include the lack of external scars, preservation of olfaction, decreased morbidity, and faster recovery time. The endoscopic surgical anatomy is something that you need to look at. This is one of our oldest videos for endoscopic decompression. So you go there, you go right up to the sphenoid sinus there, and you open up the sphenoid sinus. Sometimes you take out the bone if the bony chip is there. If the bony chip is not there, you are just doing a compression. This is another video where there is a fracture fragment. This is the orbit. This is the periorbita. This is the orbital apex. This is the optic nerve here. You can see the optic nerve here. You can see fractures there. You can take out the piece of fracture, and you can, or sometimes you can just push the bone away and decompress the nerve, or you can take out the bony piece if it is there. So endoscopy for me works very well. And we have done it with cases in which there was 6 nerve, there was no patient not looking there with a blind eye, and then you have this patient looking the other side if the decompression is done properly. Endoscopy from orbit in such cases, because if the sinus is really very bad, then you might have to do endoscopy from the orbit. We've done that with Dr. Sneha at Bombay also. So we do get very good results there. You also look at cases where there is a depression of the thing, so you might have to do a destructive osteotomy. Maxillofacial surgeons, you can do the destructive osteotomy like an Elizaro and bring the bone out so that it doesn't. Sometimes you might just have to push the bony chip away. Sometimes address the other side. So these are things that you do in management. Poor prognosis like this, I'm not going to touch at all.
Dr. Sunil, please.
Yeah. So hypoglossal, the literature for endoscopy, I'm not going to look at. And there are newer drugs in the pipeline. So we are looking at resveratrol, and we are looking at gene therapy. So these are the evidences for gene therapy based on the approach of the site. So in conclusion, advantages and risks of therapies in optic nerve injury need further evaluation. Artificial intelligence and gene therapy are the next frontiers. Thanks to all my patients. This is my email in case anybody wants to contact me. And those are my phone numbers. I'm freely available, but please be patient because sometimes I don't answer right on top.